Voices of Hello, I'm Jim Taylor, and I lead an organization called Voices of Alzheimer's. And thank you for joining our first webinar of 2025. The topic today is digital cognitive assessment. And this is part of what I think is the generational evolution of the tools that support the screening, diagnosis, and treatment of Alzheimer's disease. And at some point, a general, more dementia-friendly organization and tools. We are really very, very excited today to have two outstanding guests on our panel. Dr. Nicole Fowler from IU and Dr. Tim MacLeod from the Davos Alzheimer's Collaborative. And I think they kind of reflect the quality of the individuals who've been supporting us in our mission. They're not only professional experts, they're really wonderful human beings who we feel honored to have and get to work with. Nicole, I'll let them each introduce themselves if they will. Nicole, will you kick us off?
Sure. Hi, everybody. Thanks for joining today. I'm Nicole Fowler, and I'm coming to you from Indianapolis, Indiana, where I am a faculty member at IU School of Medicine. I'm vice chair for research for the Department of Medicine, and I sit in the Center for Aging Research, which is a group of multidisciplinary faculty who care about how to improve the lives of older adults and those who care for them. I have a couple of different areas of research. One is around medical decision-making and designing and developing programs for people living with cognitive impairment and their family caregivers. But I think the reason why I'm here today is the other area that I do is around early detection. How do we understand the risks and benefits of early detection of Alzheimer's disease and related dementia for not just the person, but also their family and the greater society? And how do we improve systems of care to be able to make detection more equitable and get access to treatment and care? Thank you.
Great, Nicole. And Tim up there in cold Toronto.
Yes, well, ironically, I think many of our US colleagues have more snow than we do in Toronto. But hi, everyone, I'm Tim MacLeod. I'm the director of the System Preparedness Program at the Davos Alzheimer's Collaborative. So I'm an implementation scientist by training, and in between this role and grad school, I ran an innovation consulting firm for a number of years. And so at DAC-SP, as we call the System Preparedness Program at Davos, we really focus on sort of understanding the readiness of health systems to absorb novel tools like digital cognitive assessments or blood tests. And so we run studies globally where broadly we're not interested in whether a tool works or not. We pick tools that are advanced in the regulatory pathway, and we really look at across sites, what are the common bottlenecks and barriers to systems actually being able to use these tools. And so typically we would find sort of barriers or facilitators at the level of clinical practice, health system operations, and the policy environment, and often intersections between those three levels. So thank you for having me today, and I'm looking forward to sharing what we're learning.
So one of the reasons these tools are so important to us is, most of you know, we now actually have FDA-approved treatments for people with Alzheimer's, and these treatments slow the advance of the disease in the early stage. It does not stop the progression, it does not reverse the progression, but this is a huge step forward for us after decades and billions of dollars invested in research to find the first treatments. And that's the stage where we are today. But wonderfully, the tools that support screening and diagnosis are evolving very quickly also. And that's what we want to talk about today. But let me just a couple of housekeeping sentences first. For those of you who don't know us, the Voices of Alzheimer's was founded in 2022 to empower people living with or at risk of Alzheimer's disease and other cognitive conditions. Our mission is to rally together to advance equitable access to the latest treatments and care, ensuring that individuals' voices and choices are respected and supported. We will begin shortly and reserve 15 minutes at the end for audience questions. So enter any of the questions that you have as we proceed in the chat window. And this session is being recorded and will be available on our website, voicesofad.com. if you want to revisit or share it with your friends. If you're not already a member of Voices of Alzheimer's, we strongly encourage you to sign on our website and join. Now let's jump into the program. Nicole, maybe you could start us out. Before we get into digital cognitive assessment, maybe you can tell us about cognitive assessment, what today's tools are, and maybe a little of the background and why they're important.
Yeah, I'd be happy to, because I think one of the most common questions I get from patients and their families is, well, how is this different than just getting older? You know, what are the differences between aging and having cognitive impairment? And I think it's, unique in the sense that, yes, the brain is an organ, it's tissues and blood vessels, similar to the way your heart is an organ and your kidneys are an organ. And as we're all aging, we know everything about our body is aging. So that's true. But the brain, like other organs, can also have things around abnormal aging that are signs of disease or some other sort of process that's happening in the body that may not be normal. And the way that we have been testing this for the brain for probably about the past 60 or 70 years, I'm not a medical historian, but it's really been around things like neuropsychological testing. And really, it's because of the way that we've been testing for areas of abnormal cognitive aging that I think has really lended itself to some of these new tools. We now, in addition to neuropsychological testing, have things like imaging. So some of you may know about MRIs and PET scans for the brain. We also now have tests that are able to look at fluids in your body, like blood or cerebral spinal fluid, to be able to detect for abnormal cognitive aging. But neuropsychological tests have been the gold standard clinically for us to determine if something is going on outside of the normal changes as people age in their brain. And these neuropsychological tests have traditionally been paper pencil. Some of you may have even taken some of these. They are things like, I'm going to tell you 3 words, and now I want you to repeat those 3 words back to me, and I'm going to ask you those 3 words, testing memory. Or it may be something like, draw a clock and put the hands at 10 past 11. That's actually something that tests executive functioning, because you need to plan the way that the numbers are, plan the hands, so it can actually test a couple of different areas of the brain. And for the longest time, we've used neuropsychological testing, mainly paper pencil, as sort of our blood pressure cuff for the brain, to be able to determine, is what we see happening normal aging or is it abnormal aging? Well, as we've been able to sort of have this major revolution in technology, mainly with computers first, and then now with machine learning and artificial intelligence, we've actually been able to take these paper pencil tests that used to require a person, sitting with you in a room for hours to be able to administer the test and then make sense of the results at the end. We've now been able to use technology to transform them into something that would be digital. So something that a person might actually take on a tablet would be very similar to the way that they would take a paper pencil. But now the computer helps us do the scoring, helps us with the administration, and really honestly makes these much more scalable. And so that's, to me, I think one of the biggest advantages of being able to take this gold standard testing into sort of current tools and technology is really the scalability, because we know that these tests really do help us determine who is aging normally versus not cognitively. And now we can actually deliver them in a variety of different settings. You don't have to have a PhD neuropsychologist, which, as we know, there aren't enough of them. And so it's really, to me, been one of the things to be able to make this more scalable and accessible. And as Tim said, there's a lot that have already been validated. In the case of, this isn't necessarily, do they work? It's more like, how do we get them to work, and how do we get them to work for more people?
Thanks, Nicole. So Tim, what is the technology change that has enabled us to move to this next step of digital evaluation? Can you kind of help us understand why it's different from what we have today?
Yeah, for sure. So I think, if you really think about, the culture of clinics, or sort of what it's like to work, for example, in a primary care clinic, a paper-based test requires a lot of skills and sort of activity and touch points. Like, you need someone to print and keep the printed copies fresh. You need someone to then administer it. You need a lot of changing. You need someone to get like a cellulite screen to put over the test and sort of mark it off. And then you need someone to interpret it and sort of work on clinical decision making. And so paper tests are very good. They've been around for a long time. There's a lot, and they work very well in some clinics. In a lot of clinics, the difference between it being feasible to do a cognitive evaluation or not is really time and resources. And so I think digital cognitive assessments sort of take forward a lot of the thinking and sort of science of paper tests and think about skinning them in a way that's just easier to use them in a clinic. I think there's also, with machine learning and some of the things that some tests are able to do, just enhanced analytics as well that may just give you more precision in measurement. But I think if our goal is really every American over the age of 55 or 60 were to receive a cognitive evaluation and really thinking about what role could a digital test play in that, I think it's really just that it gets actually adopted. And that really is a good goalpost to think about. And so I think those digital tests really streamline a lot of activity in the clinic, as Nicole said, in terms of making scoring easy, opportunities to make clinical decision making a little easier to deploy, and all of those things.
Jim, I'd like to add too that I probably should have mentioned, and Tim reminded me of this. I think the other thing that makes digital cognitive assessments actually even potentially superior, not only because of their scalability and implementability, since we're not doing much on paper anymore in medicine, but one of the biggest things I think that makes digital cognitive assessments really helpful is it allows us to pick up change over time in an individual person much more fine grained than we would on a paper pencil. And Tim reminded me when he sort of said about the analytics piece, because you really, while a one-time cognitive assessment is certainly helpful, it doesn't tell us much except for exactly what's happening to you right now in relation to the normative data that we have for people that we've tested this against. It doesn't actually tell us how you have changed.
Right.
And changing over time is really one of the most sensitive ways that clinicians can really determine if this person sitting in front of me actually has neurodegenerative disease. And I think the digital cognitive assessments, because of their analytics ability, do a much better job of helping detect change over time in individual
There's
patients.
much more precision in period to period changes than there are with the paper tests that you referred. So, Nicole, why is it so important now versus 10 years ago that people get tested with these new tools as early as possible?
Yeah. Well, I think you alluded to something when you gave the opening, Jim, about just where we are in the science of Alzheimer's disease. I think I might sort of start by saying why it's important in general, whether it's a paper pencil test or digital cognitive assessment. And, really, it's because for the longest time, there was sort of a sense, I think, within the public, and maybe even within some providers, that there was a sense of, well, why do I want to know and why bother? And I think that the evidence over the past, in particular, 15, 16 years around preventive strategies, things that are actually reversible regarding medicines that you may be taking, or even over-the-counter things that you may be taking that actually really do impact your brain. That alone, actually, I think is enough of a driver for us to want to know, like, what's going on, because there are things that we can do. So that's sort of the first thing I think when I hear, well, what can I do? Believe me, I know it's really scary. I know we still have a lot of stigma around dementia and Alzheimer's disease, but we have learned so much about what we can do to help people who are experiencing cognitive impairment and help to stabilize it, actually, even before it may become considered Alzheimer's disease. So that's, I think, the first. I would maybe even consider like non-drug reasons, in addition to the fact of people who have early cognitive decline are at higher risk of being scammed financially. We know that people who have early cognitive decline are at higher risk for medical mismanagement, so they sometimes don't take their other pills correctly, which may land them up in the ED. So there's so many good reasons why we want to know early if you're having some cognitive problems that we can help care plan around. So that's even whether it's actually Alzheimer's disease, dementia or not. Then you get into the space of, wanting to know if it is something where I have actually pathology in my brain and I might be eligible for one of the new drug treatments. And that is really critical to know early, because even the things I mentioned early, it doesn't matter. Knowing at any time, it's always important to know. But if you're really interested in being able to assess if you're eligible for lecanemab or Kisnala, you have to know early, because there is a very small window of when people are actually eligible to start taking those drugs. And so that's, I would say, in the past probably 2 years, why early detection has been even more important from that perspective. And then I think the third piece, really, honestly, is that programs, around the country, in particular Medicare, which I'm sure many of you have heard of, now actually is running a project over the next 8 years to be able to offer extra services to people who have Alzheimer's disease and related dementia. It's called GUIDE, and you can Google it. That's an acronym, GUIDE, and CMS, and there will be close to 400 programs across the country that you can actually call yourself if you think you're eligible and participate in. And so I think this recognition that there are so many things that we can do to help people from early detection sort of all the way through to end of life, we've never seen that before, and it really sort of adds to the benefits.
That's such an important message, and thank you for articulating it so well, Nicole. As you've mentioned, now we have treatment. And in the United States, we have some 20,000 specialists who deal with cognitive issues, and we have over 500,000 general practitioners. It is speculated, or studies have shown, that in a few years, as these treatments become more and more commonplace, the wait for a new patient to see a specialist in the US could increase to over 2 years. So if I want a drug that's effective in the early stage of the disease and I have to wait 2 years to see a specialist to prescribe, I may well be out of the small window that Nicole referred to, in which I am eligible to receive this treatment. So we've got in my opinion, a real crisis here in our medical system. And a lot of experts are trying to figure out, how do we deal with that? So one of the clearest opportunities, we're first trying to maximize the efficiency of all our specialists, neurologists, neuropsychologists, and geriatricians. Thank you.
Yep.
We need to move as much of the screening opportunity to the general practitioners as possible. So every year, those of us who are over 65 are entitled through Medicare to receive an annual wellness visit. So Tim, do most general practitioners, are they familiar with today's tools, and do they administer them to patients in their annual evaluation?
Yeah, I mean, let me start by saying I have a tremendous amount of empathy for primary care. I mean, it's a tough job. There are many conditions that doctors are trying to keep their hands around. An annual wellness visit is tough. It's the one time a year you might do a visit with a patient. There's a lot to get done. And there's staffing shortages everywhere that just make clinics tough. And that's globally, not just in the US. I think, the uptake in annual wellness visits is very low. Like, I think it's something like 30%. And so I think generally our experience in our studies in the US and globally is that there's a fairly low level of knowledge around brain health and dementia in particular in primary care. I think it's tempting to think about the problem as like primary care just needs to believe in this and change their attitudes at an individual level and be willing to do it. And I don't think that's wrong necessarily, but I think primary care docs are embedded in pretty complicated systems. And so, if we don't have billing codes or reimbursement mechanisms that make this relatively straightforward and turnkey for physicians, it's pretty hard to ask them to do something where they're needing to go figure out a lot of complicated back ends that they're not getting compensated to do so. And so I think it's really important in primary care. Yes, there's education and sort of understanding this better, but I think there's also the layer of how do we make operations more straightforward for clinics and for primary care docs. And so, I think our observation is there's a number of levers. So making sure incentive structures are sort of comprehensive. And for example, in the US, we sort of lack billing codes for a brief cognitive assessment. or a digital cognitive assessment that are easy to use. And so essentially you have a primary care doc needing to go from an annual wellness visit, which is quite tight, all the way to care planning. And so that's challenging. It's doable, but it's challenging for many people to absorb. And so I think there's certainly policy things. I think a second thing is a lot of education is sort of at the level of just understanding disease state. And I think that is important, but for primary care leaders, we're not talking about like oncology or diabetes practice improvement where we have a pathway that we're optimizing. Often the capability is really low, and so they need a lot of support in the complicated change management and cross-functional alignment and so forth. That is not the sort of bread and butter training of primary care leaders. And so I think there's a lot we can do there just in terms of implementation science and what we know about really good approaches to implementation that work well. Oh, Jim, you're just on mute.
I think you're on mute.
Sorry. Nicole, anything to add to that? I think Tim really described the challenge as well.
No, he's completely correct. I think that, in my experience, nobody wants to sort of wake up and say, I don't want to do this. I don't want to identify what's something important for my patient. They're in a system that just makes it really, really hard. And, if you look at all of the requirements that the annual wellness visit requires to have done to actually bill for that visit and compare it with the amount of revenue that they get for that visit, plus the sort of unclear guidance for certain things, like, for example, what tool do I use to detect cognitive impairment? They don't provide any guidance on that. It makes it really, really hard to implement.
So Nicole and Tim, as a leader of a patient advocacy organization, we want these tools. We want to be assessed in our annual cognitive. What can advocates do to further this change, to help promote more quickly this evolution to superior tools? I mean, to me, I think, the most feared senior health concern is getting dementia, specifically Alzheimer's. And it even occurs to me that if people knew they could go and have a simple screening test and understood what it was, the value of it, in their annual cognitive screening, physical, they might even increase the percentage of people who do go to their annual screening. So what can our organization and Alzheimer's Association, how can we help make this a real accessible tool to our members?
Well, thank you for asking that, because the one thing I really do feel that the medical providers, maybe I shouldn't say the system, but providers, physicians, are really receptive to when patients ask them for things, right? I mean, so, when you as a patient sort of go in and say, you know what, I don't have any concerns about my memory, but I want to get a baseline. And, I'm 61 or 68, 72, whatever. And I just want to see how I'm doing. Can you do a brief cognitive test with me today so that we can look at it again in a year? Just by bringing it up, I think, is sort of enough, just at a minimum, being able to sort of say that I'm not afraid to talk about it. I realize it's scary, but I'm interested in knowing this information, because honestly, I think a lot of providers don't bring it up, not so much because they actually, don't even have the language. They're not even sure patients want to talk about it. So I think that's the first thing, just saying that I'm willing to do this kind of test. Now, if they say, well, we don't do that here,
right?
That's what you can say was, well, where can I get that? And you know what? I actually know that there is, something on the internet that I can actually take. And there are some, I mean, they may not be as validated as sort of some others, but maybe taking, information in about something that you were able to kind of find online. I mean, again, we don't want to sort of replace physicians with WebMD, but, there are actual things that you can sort of prompt your physician to take a look at. And then I think, even giving suggestions about, is there somebody in our network that does neuropsychological testing? I mean, honestly, I think being your own advocate and being able just to say that you're comfortable talking about this is the best first step. Now, if you get a lot of resistance and they say, oh, you don't need that, you shouldn't be interested, then maybe you want to actually look at a different doctor, because maybe, there's different seasons of our lives when different doctors are more helpful than others.
Voices of
Yeah,
Alzheimer.
for sure.
Tim, please.
I strongly agree with Nicole. I mean, out of our data, specifically in the US, I think there's sort of like a couple things that come to mind, many of which I know that you're engaged in. So, I mean, obviously the US Preventative Services Task Force and looking at sort of recommendations around screening is consequential. I think that really will drive primary care. And I think the evidence has really moved in the last 3 years. So that's one sort of leverage point that we know is tricky. I think the second thing is, the incentive structures and the billing codes are challenging. And so we will need to see change in those over time if we want more systems, especially systems that are less resourced, to sort of pick this up and it not be such a lift. And then, the third thing is kind of amorphous and really in the domain of what Nicole is talking about. But, when we started doing interim data analysis on our global study on sort of early detection in primary care, you're kind of looking for things that you can solve a lot of the time. And just the most pervasive theme across like health systems and providers and patients is sort of just like a sort of consensus or consolidated view on understanding how to think about dementia and Alzheimer's disease now based on the science and sort of the value of early detection, as sort of Nicole talked about at the top. And I think, obviously at the provider level and at the system level for sure, but I think also at the patient level, like when I think about the, adults in my life that I'm close to, there just is a ton of reticence to think about asking their doctor about their cognitive health. And a lot of that really comes down to sort of better understanding the reasons why you might want to do something like that. So I think that is something that's easy to miss, but really important as well.
Thank you both. Voices of Alzheimer's is very involved in trying to help general practitioners or family physicians understand why this is so important and collaborating with other organizations. But secondly, we're also very much involved in trying to educate or inform the public about why it's so important. As Nicole talked about, we have to be responsible for our own brain health. We have to advocate for ourselves. So many of us will have general practitioners who won't be comfortable yet administering these screens. So we have to figure out how to have that dialogue with them. And Nicole gave us some excellent suggestions on how to do that to encourage the screening. One comparison that's often made is that mammograms used to be administered by specialists. But during the 60s, when articles began to appear in Better Homes and Gardens and women's magazines about why it's very important for you to have a mammogram annually, over time and continuously, to check any changes and request it of your physician. Well, that public outgrowth and request for mammograms really drove the recommendation from the task force that Tim referenced, USPSTF, United States Preventative Services Task Force, to recommend that general practitioners adopt annual mammograms. So we're hoping for a similar course in cognitive screening as well.
Jim, that's a really good analogy. And I actually sometimes use the mammogram analogy in my work when I talk about screening. And I guess there's two distinct things that also happened with that movement that I think is really important. And a lot of these things actually Tim has already mentioned. One is around, like you said, sort of changing the guidelines. Well, the guidelines get changed as a result of a change in the evidence. And so, mammogram studies had hundreds of thousands of people over years that they could actually then be able to look at the data and say, okay, mammograms changed X. And so in their case, the X was mortality. We haven't had that study yet because we don't have that drug yet. So we don't yet have a way to say early detection reduces mortality. We don't have that data yet. We just haven't made that type of innovation yet. But what we do have are these interim things that actually do measure true benefit. And that's where we need to kind of spend. So that scientists like me and sort of others are trying to say, how do we increase the evidence base around benefit that can actually change the scales for the task force? So that is one thing that I think is unique and a little bit different, but behind,
Yes.
and we're trying. The other piece about mammography, I think this is exactly what Tim was mentioning about the systems, is when you have a positive mammogram, people know what to do with that.
Right.
Your provider knows what to do with that. The specialists that, know who you should be referred to. There's a process for diagnostic assessment because a mammogram is just a screening tool. It doesn't actually tell you if you have breast cancer. You have to do a diagnostic assessment. And we have those systems in place to do the mammogram. And I think what DAC is trying to do is to build that system because we don't have that now. So I think the other stymie part is that providers are like, okay, you're helping me understand what this cognitive assessment means, but I need help to determine, how do I get the diagnostic assessment and and then how do I figure out if this is something that needs to see a specialist or if this is something I can manage. And so it's just sort of step one in being able to develop the steps after the screening. Because quite frankly, it's not fair to screen people and not do something with that information.
Absolutely. Absolutely.
I mean, I'll also say like a lot of these barriers are like common. Like we know them now. We have more evidence about them, and I think if you look at like there are bright lights in the U.S. Like what Nicole's team has done at IU is really, really impressive. They've walked through a lot of this stuff and figured it out and created their own data. Or our colleague, Brock Gaster at the University of Washington has a very pragmatic approach that fits within the existing billing codes. And so, I think I would really encourage, like, there's cause for a lot of optimism here. And I think, really looking at where people have already done this really well and amplifying this is super valuable, because I know there are very dedicated clinical teams who have spent, months and years figuring this stuff out and have some really smart stuff in terms of how they implement that most systems could really benefit from, rather than trying to walk through the forest without a map on their own.
I agree with you completely, Tim. I think there is a great deal of momentum building behind this solve this problem, and ourselves trying to say, look, our members are dying, and there's a huge urgency here to finally, now that we have breakthrough medications, let's solve these systematic problems and move forward as quickly as possible with treatment. So Nicole, you referenced back. So do you think that broader cognitive assessments and hopefully digital cognitive assessments may change the collaboration we see today between the general practitioner and the specialists, who might be the next step of a positive diagnosis?
Yeah, I mean, I absolutely. And I think that that's sort of the key. I think, I'm not sure who mentioned earlier, but the lack of specialists that we have. I think, Jim, you mentioned in some places of the country it can take 2 years to see a behavioral neurologist or a geriatric psychiatrist or somebody who can kind of help, from a specialist standpoint. But we also know actually that there's a lot of things that don't really need a specialist. When you have a cognitive screener, and then even then a diagnostic assessment, whether it be paper, pencil, or digital, there are still some things that we absolutely could immediately do in the primary care space and not necessarily, have to just sort of have a person be on a wait list. And Tim is mentioning some of these sort of innovations that we've done at IU, and there's been other examples across the country where we sort of say, okay, well, how can we help primary care figure out if this is something that, we can handle right here? Or is this something that needs to go to a specialist? And the specialists like that, because then the specialists feel, okay, so I know people are waiting to see me, but the patients I'm seeing, they're the ones that really need to see me because primary care isn't sure what the next steps are. So being able to kind of almost do a appropriate triaging, if that's the right word, to sort of figure out which patients we know we can manage in primary care and treat in primary care versus those who need to see a specialist. Because honestly, there are some folks, who do think that they need to see a neurologist. And, believe me, I have tons of neurology colleagues who are absolutely amazing and they do some really important things. And there's also some things that they're limited in that actually, primary care would be able to help manage. And a lot of it is actually things that are related to your other things that you may have going on, like your diabetes or your heart disease. And so it isn't just the brain. And I think that's one of the things that is the interface, is the digital cognitive assessments can really help us figure out who's going to get the most benefit from seeing a specialist, who can we actually help right now in primary care, who maybe actually needs to be referred for additional testing, who may or not be interested or eligible for treatment. So it really actually becomes almost a better fine tool to be able to determine what the next path is.
So Nicole and Tim, last webinar, we talked about the very exciting blood tests that we hope will begin to be in clinical practice this year. So some folks may wonder, well, now if I have good screening to identify who should be consider diagnosing, and I have a blood test that will allow me to pretty much diagnose now, and I have treatments that are available, why can't the general practitioner just complete the cycle? Why do I, if I only have such a terrible shortage of specialists, why did the specialists still need to be involved? Tim?
Yeah, for sure. So, I mean, my kind of view in our studies is sort of near term, so sort of in the next 2 and 3 years. And so we really look at the tools in terms of what the labels say right now. So, for example, a blood test, you still are required by the label to do some sort of cognitive evaluation in advance. And so, I think generally it's a tricky thing where healthcare globally, and particularly in the US, physicians are really incented to practice medicine and to work in the practice and not on the practice. And when you think about standing up a pathway that goes from primary to specialty care, there are a lot of steps from sort of how do you identify who may be at risk and find cases to how do you determine where you should watch and wait or which specialty they should go to, et cetera. And so I think, in systems where we've partnered and worked, often a lot of the resources that we give in terms of, finance goes to sort of supporting someone having the remit administratively to work between a number, like across practice areas, and sort of stitch together those pathways. And it's not a fast exercise. It requires a lot of time and thought, and it's really tough work. And so I think to some degree, incentives or resources that we can add into the system that really incentivize people to work on the practice and not just in it, as well as
Right.
tools that are not just education tools for site of care, but how do you actually do that difficult change work? That seems to be in the data that we're pulling and sort of our observation where there's sort of opportunity or unmet need today.
So I apologize to the panelists. Audience, I'm cheating because these are not questions that were on the preparation sheet, but the discussion is so good and valuable. I can't resist asking these questions because I know I've got some of the foremost experts in this topic. One thing I would like to, before we turn to questions, is, are there specific populations and regions where digital cognitive assessments might have a greater impact on accessibility and diagnostic equity?
Yeah, that's a great question. I think, can I go back to your question about blood biomarkers? Because I do, this is so important, I think, right now, because we are seeing a huge movement in the science around blood-based biomarkers. And it's really, really important because, as I mentioned, there's a couple of different ways that we help diagnose. And one is neuropsychological testing with paper, pencil, and digital imaging, which is mainly with a PET scan that requires somebody to have cerebral spinal fluid, which is not always something that people are interested in. And now we have blood. And most people have had some sort of blood work done in their lives, and it's a little bit easier. So it is really important to kind of think about this in the scale of things. On the other hand, I do think that there has been, we need to be cautious, I guess, for a couple of reasons. One is the fact that the reason why we're not using them everywhere right now is the fact that we're not actually sure if the blood biomarkers that have been tested in the labs that kind of do establish all the cut points, if they actually work exactly the same way that they work in populations that are like down the street in my local clinic. So because we don't oftentimes do a lot of research with people who have end-stage kidney disease or COPD, lung disease, or heart disease, who are maybe taking 16 different medications. So I just want to be cautious a little bit that the evidence around how these blood biomarkers work and how well they work in real world populations is still being established. So they're a tool in the toolbox, and I think they are going to eventually revolutionize the way that we do detection for pathology in people's brains. But I just wanted to kind of be careful. So for example, I would never recommend somebody get a blood test right now if they, one, don't already have a symptom, a cognitive complaint, and it's been detected on some other sort of tool, or they're not necessarily interested in finding out if they have pathology in their brain because they're not going to be interested in getting treatment. But I just think it's important to think about the fact that we're working on how to be able to make those tools sort of more scalable, and blood is one of them. And it adds to, then I think Jim kind of relates to your last question about are there certain populations and are there certain places where tools like digital cognitive assessments or even blood biomarkers are actually going to be revolutionary in detection. And I think it goes hand in hand with the conversation about the lack of specialists. I think one of the reasons why we've seen under detection, we talked a little bit about the stigma, and we've talked about lack of sort of maybe drugs, but the other piece is just pure lack of access. I mean, we also see this in lower rates of detection in rural communities for other types of conditions too. So I think digital cognitive assessments open up the door to be able to do testing, especially as I mentioned, testing over time, like so baseline and then a next year test for somebody in a rural area who really, maybe the closest neurologist is 3 hours away, and the only person they're ever actually going to see is their primary care physician. Same thing with a blood test, being able to determine, am I eligible and interested in getting treatments? And maybe that 3-hour drive to get that treatment's worth it for me, but I wouldn't know that until I actually, get the local care that I need to be able to do the both detection and the diagnosis. And I think, and then the third piece really is that just this idea that we want to be able to offer evidence-based care to people throughout the entire journey.
Right.
And making things scalable includes not just detection, digital cognitive assessments, and blood tests, but it's these systems of care. It's like being able to, even if I live in a very remote area, know that I can get telemedicine or video medicine with a dementia specialist. And
Right.
so I think that those are sort of some of the new things that are really promising.
Thanks for that cautionary note on the blood test. But, I'm a patient. I'm a caregiver. I want this all today. We've waited too long. And that's why we need scientists and people like yourselves guarding our access and the availability of these tools and ensuring that they are safe and they are appropriate for our use.
And scientists need the advocates too, because, people listen to you.
Well, I hope so. And I think together we are doing a very good job. Let's see if there are many questions. Kim, are you online? And maybe you could ask.
Sure. So we have a couple. Our first question is, change over time with digital tests is great, but how do we address the learning effect?
Okay, that's a great question. So there are learning effects, and that's true for both traditional neuropsychological tests that you take on paper pencil and digital cognitive assessments. We know that in the field, and we do sometimes take that into account. Although when you're really trying to determine, true disease versus sort of normal aging, some of the things actually aren't quite as sensitive to time over change or learning over time. And then, as we mentioned earlier, that the digital cognitive assessments can actually be much more adaptable to adjust for that. So for example, I'll give you a really simple example. Maybe for the mini cog, we use the same 3 words because that's what's on the paper. And so the person administering it is reading those same 3 words to you every year and to every person who comes in. Whereas the digital cognitive assessment allows us to adjust those words, both for you from year to year and then across people, but it still has the same type of validation for the results on the back end. So it is true, there are learning effects. We're familiar with them in the field, but I actually think digital cognitive assessments are able to be more sensitive to that.
Great answer. It's like John Brown's address in Chicago is on the test every time, on
Right.
Market Street. And so if you get it wrong the first time, you know it thereafter. Kim, another question?
Yes, 2 more. Many tests are developed and validated for very specific use cases. How can we address this when trying to replace pen paper tests with digital ones?
Okay. I can start, and maybe Tim actually probably has a lot of experience with different types of cognitive assessments. If I think I understand the question about use cases, I don't know if you're meaning sort of different aspects of cognitive functioning that we're trying to pick up. So for example, we know that some tests are better at ignoring people's education level, right? So that's been always one of the sort of long-standing complaints about these is that if I just have had more years of school and better quality school, I'm going to perform better on these. And so that I think that's one of the things over time that all of these cognitive tests have tried to improve on is to eliminate some of the bias. And so use case they're not as biased to things like education level or reading level or literacy. There's actually a lot of tests now that are agnostic to language. And so you don't have to speak English to be able to do it, or Spanish. And so that is one of the things I think that we're trying hard. And once again, similar to the technology about learning over time, or sort of sensitive to kind of learning changes. I think that the digital tools, because they are tracking some of those analytics on the back end, like Tim mentioned, when you draw a clock, for example, on a piece of paper, we're not measuring the speed at which you draw that, or maybe the hesitation or the tremors that the person has because it's on paper pencil. But we can do things like that on a digital tool. And so I think the use case actually, while there may be things that are still picking up different areas of the brain, like semantic memory or executive functioning or visuospatial, I think that the DCAs, the digital cognitive assessments, are actually becoming much more universal for picking up neurodegeneration. Almost all of these have been specifically tested for things like Alzheimer's disease and other forms of dementia. But Tim, I don't know if you have any experience with things that have been more sensitive to different types of populations.
Yeah, I mean, I definitely would say, yeah, like you've seen, tests validated on one population, much like with blood tests, and you go into the real world and they're deployed in a busy clinic without an exam room, and the local language is a different type of English with a different type of accent, and you for sure need to adjust those, and there's some complication there. I mean, zooming kind of way up, I think this is a great question, and sort of the heart of this question to some degree is just like, what does good look like? And I think it's a real challenge in the fields. If you go back to what Nicole was saying about the annual wellness visit, where there's really a lack of sort of what tool should you use, I think at the site of care for clinicians looking to sort of understand these tools, they don't have a lot of time, and frankly just want to understand what does good look like who has had the time to think about this and has sort of defined this for me. So we see this as a significant barrier to uptake in real world settings, globally, not just in the US. And so I know one of the groups who's doing work on this right now is the CEOI group, who has a digital cognitive assessment work group on this very topic. And they did something similar with blood. And we're really looking at that question of what good looks like in terms of test specifications and use cases and characteristics, et cetera. And so I know they're going through with a very smart group, sort of this use case question right now, and over the back half of the year, I think they'll have some publications to share on it. But totally agree, this is a very good question. What good looks like is hugely helpful in the real world.
Well, one of the pushbacks I hear is that the current tools, most generally MoCA and MMSE, those are the acronyms for the most prevalent tools, are not particularly adept at early stage or MCI stage, mild cognitive impairment stage of the disease. Which is now where we're particularly focused. Do you anticipate, Tim, that the DACs, the digital cognitive assessment tools, will be more accurate in the early stage detection?
Yeah, I think they're definitely more sensitive. Certainly in our early detection study, we had several sites who did a DCA test followed by a MoCA, and the sensitivity was much higher on the digital tests. And that prompted some kerfuffle at site of care because people were like, see, they're wrong, but the issue is actually sensitivity. So I definitely, I think that is something that we will see.
Kim, do you have another question?
Then this individual had a second part to this question. Unless self-administration is tested and validated, a lot of these tests cannot be given without a qualified provider. How can this be addressed?
Yeah, I mean, I totally agree with you. Like, even in sites of care without a dedicated exam room with really good DCAs that have been, validated, if an exam room is noisy and a test is done a noisy exam room, which is really different than the environment it's been validated in. You're going to see false positives. And, this matters. If you've gone through all the effort and given the resources to a clinic to change a bunch of behavior and workflow, and suddenly you're giving, pause to people about the utility of the test, I think that's very consequential. So, I know this would really ease bottlenecks in care pathways if we did have good quality tools that could be done at home. And so I think this is an important area for DCA companies to keep going after.
Yeah, it is true that there is a distinction between digital cognitive assessments that still kind of need to be like handed to somebody, like the person needs to, put in your name and your medical record number and, are you right-handed or left-handed, and hand it to you, versus, something that we can actually send to you by text, or we can send to you through your patient portal. And I think that, digital cognitive assessments, give us that opportunity versus sort of traditional paper pencil. And I think that that's where actually the field honestly is going in two ways. One is having there be validated self-administrative tools that the provider still knows that the patient is taking, but that the patient can take it on their own. It's been validated to be sort of self-administered, and then it goes right back into the patient's medical record for the provider to see, because we haven't talked much about that, but that really does guide a lot of the workflow. And then the other area that we haven't talked a lot about, but I do think it's going to be something that is also going to be coming up in the future with regard to cognitive detection, is using tools like machine learning and artificial intelligence to help us identify who may be at risk, who then needs to have some additional questions taken. Because we know that one of the pushbacks from the U.S. Preventive Services Task Force has been the cost and benefit of screening everybody to pick up a certain percent. But if you're able to, without cost, to be able to say, well, I've got 1,000 people in my practice who are over 65, and of those 1,000, I know based on epidemiology who may have something, but I don't know which ones those patients are. Can we do something that allows us to pick up a patient who's at risk, and then sort of be much more precise about who needs additional testing? So that's another thing I think that we're working on, is how do we ethically, but also passively help us understand, who's at risk, who we can start to work with, versus those who aren't at risk and don't have any concerns.
I like that.
Yeah, it's a great point. One of the tricky things as well about, there's kind of two ways to look at this, right? Like, one is if you have tests with increased specificity, you're able to hand over the right patient at the right time, and you sort of decrease the number of people going to neurology or specialty care who may not need to be there. And that's great. It really helps systems because of the shortage of specialists. On the other hand, if the goal is to get screening or early detection in primary care broadly, I think waiting for those tests with increased specificity, especially if they're hard to use versus, for example, paper and pencil, can also be an odd way to look at it as well. So I think there are sort of two sides of that coin. I don't think there's necessarily a right answer, but I think it's a good trade-off. And the reality is it probably depends on the systems and the resources that they have and the number of specialists and type of specialists. But I think it's worth sort of looking at that question through two lenses.
This is a great conversation. I think not only are you both so well informed, but you both have a gift for speaking to people like myself who don't know or understand the science, and really help inform the public. And Nicole, you pointed out how important that is, that people have enough knowledge of what's happening today that we can ask and dialogue with our physicians about what needs to be done. So I can't thank you both enough. We've got a few minutes left. Would you like to make any additional comments, Nicole, to our audience, closing ideas or thoughts?
I think the other piece, and I'll sort of put a plug in. I think that not only advocacy and sort of talking with your provider about things that you think are important. The other piece is we have so much need for people to participate in research, and I spend a lot of my time. I realize I'm in academics, and we live and die by proposals and sort of people agreeing to participate. But honestly, I think the other area, the other push that's going to sort of, in addition to advocacy and science, that's going to help is we need participants. We need people who are interested in, and it's not always something that's invasive that requires even a blood draw. Sometimes it's just things like, answering your phone once a month and asking, answering some questions from somebody, or, being willing to answer a survey. And so I always sort of put a plug in when I'm talking to groups like this, that don't be afraid to look for projects that you could participate in, and they're not all scary. They don't all require you to drive somewhere and participate in an MRI. Some do, but not all. And so I hope that people will be interested to be able to look and see. I know the Alzheimer's Association has a website called Trial Match, where you can look nationally. The National Institutes of Health have listings for people to participate. And then, of course, if you're close to a university, they also have usually a lot of information for participating in projects. So I hope you'd consider. Tim?
Oh, Jim, you're just on mute, but I think you're maybe asking me the same question.
Tim.
Yeah, I mean, so I'm kind of a relative newcomer to Alzheimer's and dementia. I've been, working in the field for about 3 years. My background's in mental health, and previous to that, I'd had 2 grandparents that we lost to dementia. And so, when I started getting immersed in the space, the complexity of it, I found really overwhelming. And, today we talked about a lot of different barriers and a lot of ways in which things need to change. And I think with some time and getting to spend a lot of time with sites like Nicole's at IU, or our colleague Ishtar, who led one of our sites in Jamaica, who's on the call, I'm just constantly amazed and inspired by systems figuring this stuff out. It's really hard. There's a lot of dedication. So many systems have done a really good job. And I think there's a lot of optimism in that. Like, I know that we all want change to happen really, really fast. And in some places we're seeing it happen fast. And for my team, our goal is really how do we scale that and move it as fast as we can. But I think there is cause for optimism when you look at the last sort of 20 years of what's been available to patients and families. I do think things are really accelerating today. And so, I would just encourage people to also sort of look to some of the optimism in the space as well and what's possible.
I couldn't agree with both of you more. Jerry and my late wife and I have worked very hard to try to increase participation rates in clinical trials, because we're not going to find a cure unless we do that. And Tim, I think the magic word for us now is hope. The FDA approval of disease-modifying therapies has brought so much help, so much hope into our community, that we need to capitalize on that hope and move forward with the challenges that remain in front of us, and really drill down and make some more progress. So really tremendous thanks to you, Nicole Fowler at IU, and you, Tim MacLeod at DAC. Wonderful, wonderful conversations, and thank you so much. And best of luck in your continued pursuits. Please join us next webinar. We hope we'll have you back for another exciting and educational topic. Thank you, guys. Great hour.
Bye, everybody.
Thanks for having me.